So let me start my presentation entitled Medical Research for Clinical Applications. There are 4 contents of the presentation, and the first theme is the research background and introduction of our team. So on January 20th, 2015, in his New Year's State of the Union address, the US President Barack Obama announced that the cancer and rare disease would be targeted by examining how genomic information, environment factors, and lifestyle affect the health maintenance and disease development using large clinical samples to the precision medicine initiative. So, which divides patient potential sufferers into the subgroups for morbidity and develops appropriate treatment and prevention methods for each group. I also introduced the point of the precision medicine initiative, a total budget of US $250 million, and the construction of a national research cohort of more than 1 million volunteers using US $130 million to help participants to collect a variety of information, including medical record information, genetic information, metabolite information, microbial information in the body, and environmental and lifestyle data read by the National Institute of Health. Actually, the identification of the cancer driver genes and development of a more effective cancer treatment using US $70 million led by the US National Cancer Institute, and reviewing the current relations to advance precision medicine, acquire expertise, and build a highly accurate database using $10 million led by the US Food and Drug Administration. Actually, the establishment of and comprehensive operational standards and requirements for privacy, prevention, and life forms exchange systems using $5 million led by the US National Health Information Technology Coordinating Officer. After this statement, we call the personal medicine as precision medicine. The definition is now the era of the precision. The Barack Obama, this statement strongly affected the policy in medicine, not only the United States, but also all over the world. And then, so I always committed the personal medicines in my research life. That is, I'd like to explain the importance of the personal medicine, precision medicine, and medical research according with my career. Around 20 years ago, I studied in the medical science of the University of Tokyo. As that one of the most important topics anyway, the Human Genome Project organized by the International Committee, which was completed in 2003 after 13 years and a cost of about US $3 billion. And the head of our institute, Dr. Sakaki, is a leader of the Japanese genome project, and they analyze the chromosome 21, and this is a press release from Nature. Then, after finishing the Human Genome Project, the medical science enters the new era of post-genome era, and we launched the Biobank Japan project, mainly the University of Tokyo and RIKEN. And my former boss, Yusuke Nakamura, organized this project. So enrollment of the approximately 270,000 people with 51 disease as a disease cohort. Even now, this is one of the largest biobank all over the world. Since 2004, I studied in University of Cambridge. Why I chose University of Cambridge is there are several my respected researchers, including Frederick Sanger. And Fred Sanger, as you may know, developed the Sanger sequencing, which made it possible to decode genes, and was twice awarded the Nobel Prize in Chemistry in 1958 and 19 2008. And the Sanger method for DNA sequencing has long been a core technology for genetic sequencing, including the Human Genome Project. And one of the important events during my stay in Cambridge is the appearance of next generation sequencing. On the basis of this machine, the field of genome analysis drastically changed. In 2008, I returned to the University of Tokyo, and one of the serious incidents in Japan is a Tohoku earthquake in 2011. And the Japanese government launched the Tohoku Medical Megabank. This is conducting a health survey of 150,000 people mainly in the disaster area to form a prospective population cohort that includes genomic information, as well as Biobank Japan. This is also very important resources in Japan. From 2012, I moved to the University of Chicago Medicine as an associate professor. As one of the important progress of this piece is the evolution of the NGS to achieve the 1,000 genomes. So in 2014, Illumina announced that HiSeq10 established 1,000 genome, enabling whole genome cancer genome and 1 genome per day analysis with 30 times coverage. That this change drastically affects the field of medical science because just as I mentioned, in 2000, for analysis of the one whole genome, this took 13 years and the cost of about $3 billion. But now, less than 1,000, and time is within 1 day we get the result. And as important to the topics in precision medicine is the member of the National Cancer Center East launched the Scrum Japan project in 2013. Approximately 260 medical institutions and 70 pharmaceutical companies across Japan are participating in the project, aiming to develop the therapeutic and diagnostic drugs tailored to the genetic abnormalities of each cancer patient. I think this is very, very important, the trials and the beginning of the precision medicine in Japan. Since 2016, I returned to the National Cancer Center in Japan and also the RIKEN AIP Center, and I am conducting the medical AI research. Why I chose the medical research is the progress of the technology, including the NGS. Now we get the huge amount of data. For example, one whole genome analysis produced around 1 terabyte data. And as you know, the human gene includes 3 billion nucleic acids. So it's very, very huge data now we need to organize. This is, I think, above human ability. That's the reason we need to cooperate with artificial intelligence for the establishment of the advanced medicine, like the precision medicine. Actually, the University of Chicago is very famous of the radiological field and the pioneer of the medical AI. So which also gets the inspiration and the importance of the medical AI in Chicago. That is now actively conducting the medical AI research in both RIKEN and National Cancer Center. And other important topic in Japan is the Ministry of Health, Labor, Welfare launches the Center for Cancer Genome and Advanced Therapeutic, we call it CCAT, in 2018. And the purpose of this project is to bring the world's most advanced cancer genome medicine to the public as quickly as possible. Okay, and I am the first speaker. A little bit explain about the background of our research, in particular the national AI strategy from the government. So this is the Prime Minister's official the resistance and the statement. The technological innovations such as medical treatment support, telemedicine, watch for you rating, and robotics using ICT such as AI and IoT should be incorporated into the framework of the medical and nursing care with sufficient evidence in the form that the field and the public to realize the effect. In this, there are six important topics. The first topic is AI-based medical support. Today, we also introduce our achievement. And the second is medical ID. And third is medical cooperation network. And fourth is maintenance and consolidation of public database. And fifth is the realization of the anonymous processing and provision and organization for medical information, the tentative name. And sixth, fundamental reform of the comprehensive nursing care insurance database. Yeah, because I'm not joining the public institute, both the RICAN and NCC, I completely follow the government policy, national AI strategy. Based on this policy, I started the new team called the Cancer Translational Research Team. I would like to introduce our team briefly. And the AIP Center, RICAN AIP Center is one of the largest artificial intelligence research centers in Japan and builds innovative artificial intelligence infrastructure technology that leads the world. And the National Cancer Center Japan is the largest center for cancer research in Japan and the Center for Cancer Control in Japan. The quantity and quality of cancer-related information and data are among the highest in the world. So our mission is the world-class quantity and quality of cancer-related data accumulated at the National Cancer Japan will be analyzed using RICAN's cutting-edge technology and applied to the diagnosis and treatment of cancer. We now conducting the several research, and I'd like to introduce some main research topics of our teams. There are two main topics. One is medical image analysis, including endoscope image, ultrasound image, and radiation image. And today, at first, I will introduce the endoscopy AI project. And the next, Dr. Komatu introduce the ultrasound AI project. And the other main topic is omics analysis, including genome analysis, epigenome analysis, and multi-omics analysis. And I think the machine learning and deep learning possesses very important characteristics. For example, the multimodal learning. So we can integrate different types of the mixed data, like the genomic data, epigenetic data, medical image data as input. The second important point is multitask learning. So we can increase learning efficiency by running several different tasks at the same time together with sharing some component of the learning process. The third is representation learning and supervised learning. It's known that unlabeled data, when used in conjunction with a limited amount of the labeled data, can produce a considerable improvement in learning accuracy. And fourth is automatic acquisition of the hierarchical features. We can analyze the high-dimensional correlations of input data. Although it was difficult to have all such characteristics by the conventional analytical techniques, a number of the machine learning and deep learning technologies possess these features. That's the reason now we use these technologies for omics analysis. Today, the third speaker, Dr. Asada, will introduce our achievement of the omics analysis. Okay, next topic is endoscopy AI project. This project is in collaboration with the endoscopy division in National Cancer Center. In particular, the Dr. Masayoshi Yamada, he's a medical staff in the hospital, actively proceed with this project. Okay, so since neoplastic corrector polyps cancerous lesions, detecting and removing them during colonoscopy can inhibit their progression to colorectal cancer. Physicians detect the polyps by macroscopic observation, but polyps are easy to miss if they are small or the shape is not clearly defined. So to address these issues, we developed the real-time endoscopic diagnosis support system using AI. This is summarized the figure of our real-time endoscopic diagnosis support systems, algorithms for morphological detection of the regions using deep learning AI and high-speed processing algorithms plus the GPU. And the very important point is, anyway, for clinical application, we selected the real-time feedback system. This is our strategy for algorithm creation and training. So regions are the polyps as precancerous regions and early-stage colorectal cancer. The first step is building the data set with regions present, endoscopic image database and video, and no regions. And the physicians annotate these figures and conducted the supervised deep learning using the approximately 12,000 regions and approximately 250,000 no region images. We call this system the wide vision, the endoscope image, supporting endoscopists in detecting the regions and improving and enhancing the diagnostic accuracy by bringing doctors and AI together. The endoscopic examination and the video signal are recognized by our AI system, wide vision, and the circle symbol, the analytical result, and the notification sound. Okay, this is a real video image, the 25 millimeter. I'm so sorry. The mainly, I'm not sure very high data. High volume data affect the progression of my presentation. I'm so sorry. I continue. So anyway, we developed the wide vision endoscope image analysis AI. And this is the real video image, the 25 millimeter protruded region. The in addition to this okay, the image and also the alarm is beeped. Okay. This is a real video image, the 15 millimeter early stage colorectal cancer. And this is a 5 millimeter protruded regions. And this is a 3 millimeter superficial region. And this is a 3 millimeter superficial region, 02C. And this is a 40 millimeter superficial regions, lateral throat tumors, LST. Okay, we have already performed clinical studies we call the Design AI-01 studies. Verification hypothesis is this AI system detects the colorectal precancerous lesions and early colorectal cancer as well as the skilled coloscopist. And first step is colonoscopy videos, initiation hospital from July to October in 2018, and confirmation of the image data via endoscopists outside the hospital. And pick up the 350 regions and 4,000 segments of the video without the regions, 0 0.56 per segment, and AI performance evaluation test, the 100 sections with regions and 50 sections without regions. The evaluation item is the percentage of the 350 corrected precancerous regions or early colorectal cancer regions correctly detected. A correct answer is one in which 5 or more frames are judged in a row in one section of the video, and the degree of the false positives. And also the physician reading examination. After randomization, the normal monitor only, and normal monitor and AI monitor. This is the accuracy of the AI after conducting the our clinical trials. The sensitivity is for the protrude is 95% and superficial is 78%, and specificity is 89%. And with regards to the sensitivity, we correctly detected at least 5 consecutive frames. Then this is the physician reading examination. The left panel shows normal mode, just physician around groups. Sensitivity is like this, and AI combined group is like this. In an observational study, physicians with limited experience in colonoscopy use this AI system in conjunction with the system, resulting in approximately the 6% higher detection of the superficial regions. And a very important point is we got the approval from the PMDA in 30th November in 2020. Yesterday, we conducted a press release to all over the world. Important point is, in addition to Japan, our equipment is already got the CE mark, so which means that our medical device is can be used in not only in Japan and but also the Europe now. And this is the actual medical treatment using wide vision. Left side is the original monitor, and right monitor shows the wide vision. So physicians can check both monitors. The advantages using wide vision is firstly an AI system that can detect typical and atypical cases by training from the endoscopic images of more than 10,000 early stage colorectal cancer and precancer regions accumulated at the National Cancer Center Hospital. And this AI system can comprehensively and instantly analyze the entire image projected by the endoscope. By having the endoscopist and AI work in unison, the endoscopist is able to be aware of the area that the endoscopist was not aware of, which is expected to improve and enhance the accuracy of diagnosis. Also, the thirdly, this AI system can be connected to endoscopes from the 3 major endoscope manufacturers. This is very important because our system is vendor neutral. Simply connect your existing endoscope to a terminal and monitor equipped with this software to start using it immediately. So future prospect, we will improve the accuracy of the AI by having it run to recognize flat or the depressed regions that are difficult for humans to recognize. And it also aims to address the quantitative diagnosis of colorectal region and the prediction of the lymph node metastasis of colorectal cancer. And by linking CT images, pathological images, molecular biological information, and other information, we aim to develop the multimodality real-time endoscopic image diagnosis support system that's more highly useful, and we further promote development of research trials, realization of the advanced and personalized medicine and remote diagnosis. Okay. And third topic is challenges of medical AI research. As you know, there are huge opportunities to develop the medical AI. Definitely, that it's useful for the clinical setting. But also, I always think the AI possesses several issues. For that reason, I would like to explain about the main issues of the medical AI. The first issue is, I think, the overfitting. So overfitting in machine learning, deep learning technology refer to the situation where the generalization error, the error when judging unknown data does not become smaller, even though the training error is small. Especially in the medical field, where the number of training data is limited, it always necessary to carefully judge the generalization performance of the constructed mode. I think that the validation is especially important when aiming for social implementation. In the EndScope project, clinical trials have already been completed, but we believe that the clinical trials, especially the prospective ones, are more important than for conventional medical devices. And the second issue is the black box of the AI. The analysis process of machine learning deep learning technique is a very complex, which creates a black box problem where humans cannot understand the analysis process of the result obtained. If a system has a black box, it's difficult for designers or users to predict the behavior of the system during the design or use, which hinders the system from being secure. In Europe, the General Data Protection Regulation, GDPR, which came into effect in May 2018, includes an article, we call Article 22, that requires transparency AI. So it's necessary to address the black box issues in terms of the compliance with GDPR regulation. And I think there are three main approaches being implemented to improve the interpretability of machine learning and deep learning. The first is deep explanation, using deep learning state analysis to generate attention heat maps and natural language explanation. The second is interpretable models, machine learning, using models that are already highly interpretable to improve the accuracy of white box machine learning. And the third is model induction, the external creation of interpretable models that approximates the behavior of black box machine learning. And third challenge is the discrepancy among facilities, especially in the medical images, ensuring robustness. So when medical images collected from the multiple facilities, such as radiological images analyzed by AI, the characteristics of each facility are often observed more prominently than the characteristics of the disease states. We call this domain shift problem. This is thought to be due to the differences in the manufacturers and model numbers of the medical devices used, as well as the differences in the protocols of each facility. In order to avoid this problem, the techniques such as the domain adaptation have been developed. Lastly, briefly, I'd like to introduce the Japanese Association Medical Artificial Intelligence. So just as I mentioned, we have a lot of issues to develop medical AI to overcome, not only the small, but also maybe the large groups, not only the professional of the AI or medicine, but also some the other ethics or law or something. So that is now we are organizing the Japanese Association for Medical Artificial Intelligence. The uniqueness of this society is an academic association on artificial intelligence with a large number of medical-related members, unique in the world. And if you are interested in this our association, I will recommend you to join the societies. Please let me know. Additionally, now we also conducting the official qualification of JMAI. The lecture materials for the certified qualification are used by a wide range of the people in both academia and industry, including the graduate students at former Imperial University, and have been very well received for the high quality. In addition, a certification card, license card, is issued to those who have passed the certification examination, and many people write in the qualifications columns for medical specialties. So the exam format will be completely online. So if you are interested in this certification, please take the exam. Okay, this is acknowledgement. I'd like to show my greatest gratitude to all collaborators of our project. Thank you for your cooperation at all times. I am so sorry that sometimes some the slide troubles. Sincerely apologize for any troubles caused. Thank you. So let me open for free discussion. If you have a question or a comment, please let me know. So you can use, okay. Okay, the first question is on remote diagnosis devices emitting signals like mobile phone acceptor. So thank you for your question. Maybe this is, we can use mobile phone, such kind of diagnosis. This is, I think, regulation issues. So as you know, in Japan, there are several laws related to medical treatment. So that reason, at first, we need to get to the acceptance. We have just got to the acceptance as a medical device from PMDA. Just this is for the clinical usage, which means that a certified medical doctor can use this equipment. But if the mobile phone can use such a kind of diagnosis, maybe the uncertified people also use. In such a case, technically, I think it possible, but regulation issues seriously affect the acceptance. This is a little bit different story, but in addition to the endoscopy images, I also now analyze the various kinds of the images, including skin cancer. In the case of skin cancer, the physician can use the normal camera. So, which means that compared to other fields, in the case of the endoscopy, this is completely the medical device. But camera itself is not a medical device. In such a case, maybe ordinary people can use. And indeed, now we try to use mobile phone to check the malignant melanoma or the folds. So today I don't have enough time. Just I introduce the endoscopy, but other project, we plan to use such mobile phone to check the diagnosis, in particular the skin disease. Yeah, because ordinary people can use such kind of equipment for check. But also that there are regulation issues. So now we are discussing with the Ministry of the Health, Labor and Welfare and how to proceed with this strategy. If we don't use some specific device, medical device like camera, in particular maybe the skin disease, because we can see directly. But in other cases, using endoscopy or ultrasound or the radiation devices, certified doctor or the staff should handle at this moment. So that is, this is very important question, and we need to improve or the minor change of the law is needed. Thank you for your questions. Any other question or comment? Okay, thank you so much. And I do apologize for any inconvenience caused based on our terms. I'm so sorry. Okay, I finished my presentation. Okay, the next speaker is Dr. Masaaki Komatsu, please.
Okay, my name is Masaaki Komatsu. My presentation title is Development of a Diagnostic Ultrasound System Using AI Technology. So let's start. Okay. In recent years, deep learning technologies have been developed rapidly, so there is much interest in the adoption of deep learning for medical imaging, including X-ray, CT, MRI, and histopathological images, and so on. Compared to other modalities, ultrasonography, ultrasound, it can be abbreviated to US. It is superiority and non-invasiveness, real-time performances, and also the equipment innovations. It means the equipment become smaller and easy to carry, and also the improvement of the image resolutions. So this US is widespread used in a wide range of clinical medical fields. However, the US image analysis is still challenging because US has characteristic issues. The first one is manual operation. The right upper figure is showing usually the examiners handling the US probe, and so there is a lot of technical differences among examiners. Another issue is the noisy acoustic shadows of bone or other obstructions, and showing the right bottom figures. It easily affects the image quality and diagnostic accuracy. These issues causes the regional disparity of healthcare. For example, with respect to fetal cardiac ultrasound screening for congenital heart disease, it requires high skill levels and experience, and shortage and uneven distribution of statisticians causes a regional disparity of healthcare. Lower left figure showing prenatal diagnostic rate of CHD, even in the high expert medical center. The red bars represent the prenatal diagnosis, and blue bar represent the postnatal. So the prenatal diagnostic rate is around 50 to 60%. And right figures showing the regional comparison in prenatal diagnostic rate of CHD, and there is a regional disparity of the diagnostic rate. So it is expected that the AI-based technologies resolve these problems. So our team's object is to develop the diagnostic support techniques for examiners in ultrasound. As a first step, we work on the above mentioned fetal cardiac ultrasound screening. First, topic, I'd like to show the first topic of object detection. Because of the relatively rare instance of the CHD, and also we refer to the expert, the estimate the cardiac substructures whether in the right position or not. So we propose a supervised object detection with normal data only. We abbreviated the sono in ultrasound videos. First, we made the cardiac substructure detection and using the data preparation for the over 700 ultrasound videos. And in this project, the point is we just annotated the 18 cardiac substructures and over 8,000 images from normal, just from the normal fetal ultrasound videos. And then we visualize the detection result as a barcode-like timeline. The figure showing the ventricular axis showing the selected 18 cardiac substructures, and horizontal axis represents the examination timelines. A probability of the detection of each substructures over 0.01 show the blue bar as well detected, and under 0.01 as undetected. And upper one is a normal case, and bottom one is a CHD case. And compare these cases, the red lined area is the difference. So the barcode-like timeline is informative for examiners to capture each cases of characters. And also it is expected to acquire one of the important features of the medical AI, development of explainable AI. Then we apply to the detection of cardiac structure abnormalities. We use the 84 videos of the vessels and showing, and our method sono showing the blue lines, and compared with the conventional anomaly detection algorithms. And the result, our method performed, the superior performed to other for conventional methods. And then we integrated our mentioned technologies and proposed a graphic user interface for clinical implementation. Left window showing the ultrasound sweep scanning ultrasound videos, and suppose the color bounding boxes. Each cardiac substructure is supposed to be in the where in this existed. And the right upper table is showing the probability of each cardiac substructures, and right bottom figures showing the calculation of the abnormality scores. And also after the whole examination, click the report button and showing the probability maps, the barcode-like timeline, and as a report. let's move to the second topics, the image segmentations. The first target is a ventricular septum. That is one of the cardiac substructures which are small and change shapes dynamically with fetal heartbeats. So it is difficult for object detection and general segmentation to detect it accurately. So we showed our ingenuity to resolve these problems. The A showing the cropped image, and B showing using the time series information. And then we propose a cropping segmentation calibration abbreviated to the CSC. The CSC employs the time series information of videos and specific section information to calibrate the output of UNet. And then we evaluate of the segmentation results. Left figure is showing the examples of the ventricular septum segmentation images in test data. And in result, compare with UNet and Deep Lab V3 plus our CSC, and CSC show the better performance than the other conventional segmentation methods. Next, we target to the thoracic wall. The thoracic wall is a key structure on the assessment of the chest region for examiners to recognize the relative orientation and size of structures index the thorax. Thoracic wall show the middle figures. It consists of the ribs and spine and muscles. And this structure is important to the measurement for the cardiac indexes, lower three figures showing to estimate the congenital abnormalities. First, we test the segmentation of the heart and lung and thoracic wall using the conventional segmentation methods. And in this result, we recognize the thoracic wall is difficult to detect than the heart and lung. So we propose the novel method using the time series information and using the shape of the cylinder. First, annotated the thoracic wall and generated the thoracic cavity and whole thorax. And using the training with these thoracic wall and thoracic cavity and whole thorax using UNet or deep level, and then using the target image and neighboring frames and segmented use this model, and after that integrate the multi-frame method and cylinder method. And then evaluated the segmentation results using the deep lab 3+ and UNet with without MFCY. And from this table, the MFCY increased the mean values of IOU and DICE of thoracic fold segmentation. So MFCY is expected to provide further accurate segmentation for the thoracic wall. And this is final topics and shadow detection. And shadow detection for ultrasound images, we propose an autoencoding structure for estimate the shadow area and intensity. This model is first split the input images to the shadow images and non-shadow content images, and then combine to reconstruct the input. The synthetic shadow generating using the knowledge, domain-specific knowledge on US images. So we can train the model using the unlabeled data. And comparison with the conventional methods, our method showed the better performance. And as a possible application of shadow detection is a pre-processing assessment of the US image quality. The input the image and split to the shadow images after the some kind of binary segmentation something, and estimated the influence of shadows on diagnosis. So we can use the quality inspections. If it estimated low quality, it can lead the examiners to do the re-examination. This method is can use to the cross-disciplinary in US. So we can expand this method to the adult cardiology or cancer screening and so on. This is a summary, and the US image analysis is still challenging owing to its manual operation and noisy acoustic shadows compared to the other modalities. And second, we have to show ingenuity in developing US diagnostic support techniques for examiners. In this study, we propose a sono, CSC, MFCY, and shadow detection demonstrated the superior performance to the conventional methods. These these techniques are expected to expand to other US fields. This is the final slide. I'd like to show the acknowledgement to our team members and collaborators. Thank you for your attention.
Thank you for your presentation. Let me open for a free discussion. If you have any question and comment, please write on the Q&A or please let me know. And there are one question. So if I understand well that you applied AI or machine learning method to ultrasonography image post-processing, would it be integrated to use AI at earlier US data stream steps, raw data filtering before imaging, or even guiding the USG probe by a robotic arm?
I know the result of manual operations problem. I agreed using the robotics or something. I hear the news, maybe in China or something, and the corona infection situation, robotics is utilized to checking the US check for avoid the infection. So I think it is one possibility to resolve these kind of problems.
Okay, the second question is for shadow detection. Why is the test data less than 1% of training data?
Okay, just now, this is a preliminary data. So we are increasing the testing data. And just now we are preparing the publication. Please check our updated data.
Okay, let me move on the third speaker. Okay, the third speaker is Dr. Asada. Please wait. Okay, please start, Dr. Asada.
Thank you very much, Hamamoto Sensei. This is Ken Asada, Cancer Translation Research Team at Riken AIP Center. Today, I'm going to make a presentation entitled Multiomics Analysis to Approach Lung Cancer. This is the importance. Here is the importance of machine learning and deep learning for mix analysis. Actually, Hamamoto Sensei has already explained with the same slide, so I will give you a quick reminder. Fast multimodal learning, because genomic data, epigenomic data, medical imaging data, and etc. can be used for the medical research, so that integrating different types of mixed data is really important for mix analysis. The second thing is multitask learning. This is literally multitask learning, to increase learning efficiency by learning several different tasks at a time or spontaneously. Third is a representation learning and semi-supervised learning. If you work with the big data, making all the labeling or making all the annotation is really tough. That is why representation learning and semi-supervised learning is quite important for the mix analysis. And fourth, automatic acquisition of hierarchical features to analyze high-dimensional correlations of input data. So in this slide, what I want to say to you is that it is difficult to have all such characteristics by the conventional analytic techniques. Therefore, machine learning or deep learning technologies possess all four aforementioned features. That is why it shows the advantage of these technologies in especially medical research. That is what I'd like to say in this slide. Here is the objective of the multiomics project. Like genomic or epigenomic or transcript data can be integrated as a multiomics data. And these data can be analyzed by ML or DR, which is machine learning or deep learning analysis, for comprehensive understanding of nature of cancer and towards precision medicine. The reason why we are focusing on the lung cancer is lung cancer is the leading cause of death in worldwide, not only Japan, but also the other advanced developed countries. This is the statistics of incidence and mortality in Japan 2018. You can see lung cancer is ranked as the first place in both new cases and deaths. This is our cancer mutation profiling in TCGA and NCC biobank data sets. TCGA, this is a Caucasian data set, and the National Cancer Center data set is a Japanese data set. You can see the huge difference between them. KRAS mutation is mainly occurring in TCGA Caucasian patients. However, EGFR mutation is over 50% in Japanese lung cancer patients, suggesting if we would like to address the mechanisms in Japanese lung cancer, we need to use the Japanese cancer data set. That is why Hamamoto Sensei and other collaborators are actively building the Japanese data set as a part of PRISM project I have shown in the right table. And this is now becoming one of the biggest data sets in lung cancer. So here is the strategy. Step one, develop the pipeline by using TCGA data sets. The advantage of using TCGA is because this is a publicly available, and this is one of the biggest data sets so that we can make use of their accumulated knowledge. So today, I'm going to explain the results obtained from the step 1. And step 2, this is the future work. Multiomics analysis can be done using Japanese data sets because the background is totally different between TCGA and NCC cancer or Japanese data set, as I explained before. This is a workflow for the integration using a TCGA assembler, which is published in Nature Method in 2014. We just followed this pipeline to download the omics data from TCGA datasets. So 6 omics data are available: somatic mutations, copy number variants, DNA maturation, microRNA expression, gene expression, and protein expression with clinical information. Lung cancer subtypes available in TCGAs are lung adenocarcinoma, lung squamous cell carcinoma, and mesothelioma. We decided to focus on lung adenocarcinoma because this is the biggest data set and this is a major cause of lung cancer. Also, we downloaded the microRNA expression and gene expression data because microRNA interact with the RNA through the Watson-Crick base pairing, so that the results obtained from the multiomics analysis can be interpretable. That is what we we thought before we started to study the multiomics analysis. This is the overall workflow of this study. Data assembling has already explained one slide before. And here is the data preprocessing. And the data are dimensionally reduced by autoencoder. And the bottleneck features were further selected by COX-PH to select survival-associated features. And these features are performed by the k-means clustering for clustering, and obtained label of analyzed for the survival analysis, or there's a prognosis by using developed classifiers. So for the data preprocessing, we decided to use multiomics data, not the single omics data. So first, the single omics data were concatenated to make a multiomics data like this. And we also chose a standardization because the expression levels of RNA and microRNA are varied, which means our variance is really huge, so that we chose to use a standardization for the data preprocessing. And this standardization was done against each patient, not in genes, because we'd like to extract the features of interest in patient, not in genes. Here is the inputs. 13,767 were encoded into a bottleneck feature space of 100. And here is the more details of the autoencoder. We chose the epochs of 150, but from 100 to 200, the result is always consistent and stable. Here is the hyperparameters: learning rate, activation function, loss function, optimizer, dropout rate, L1 and L2 regularization penalties. The bottleneck features of 100 were further selected by the COX-PH model, and we obtained 33 features from them. Using these 33 features, k-means analysis was performed, and we obtained k equal 2. So using these labels, we analyzed the Kaplan-Meier analysis, and we are able to separate the high-risk subgroups from low-risk subgroups. So next, to predict these omic subtypes or high risk or low risk subtypes, we aimed to develop the classifiers, which is a support vector machine. We systematically investigated the number of inputs. And when we used 20 microRNAs and 25 RNAs as an input, we get the best performance to predict the patient's subtypes by support vector machine. We also developed other classifiers such as k-nearest neighbors, random forest, and logistic regulations. However, support vector machine is the best classifiers to predict omic subtypes among classifiers. This is concordant results of other published papers. So as long as we follow the multi-omics pipelines like omics data integration, dimension reduction by autoencoder, and feature selection by Cox-PH, we don't know the reason why, but SVM is the best classifier to predict the patient subtypes. And this is the microRNA and the iRNA we used to develop the classifiers. For example, MIR21 and MIR10A interact with the CPM, and MIR143 bind with SFTPB, suggesting although we use the autoencoder, the results we obtained from this multi-omics analysis can be interpretable, as we expected before we started the experiment. This is the characterization of the two omic subtypes. You can see new tumor events is highly observed in high-risk subtypes. And we also examined 80 genes that are reported as significantly mutated in lung adenocarcinoma in Nature in 2014. And we found that NF1 is highly mutated in high-risk subtypes. Other 70s, there's no significantly statistically significant. This is the results of gene set enrichment analysis and high-risk subtypes. Oxidative phosphorylation, Wnt beta-catenin signaling, and KRAS signalings are highly enriched in high-risk subtypes. So we can summarize that if NF1 is mutated, RAS, BRAF, MEK, and ARC signaling is activated, and the cell would be more proliferative. So this is, we think, one of the mechanisms happening in the high-risk subtypes. In low-risk subtypes, judging from the gene set enrichment analysis, information such as IFN alpha or IF gamma signalings are altered. Through this multi-omics analysis, we found several genes that are associated with patient survival. There are many of genes are differentially expressed between low-risk subtypes and high-risk subtypes. We only selected 25 genes, top 25 genes, and we found 6 out of 25 genes are associated with the patient survival, depending on their expressions. To be honest, DBY19L1, MARCH1, SLC7A8A, this is our first report that these expressions are associated with patient survival. We only investigated the top 25, but if we move on to and dig into the top 50 or top 100 or even top 20, we may be able to find out and identify more genes that would be associated with the patient survival, and we will continue to work on it. So the basic multiomics analysis has already developed. So we decided to move on to the advanced multiomics analysis using 6 omics data using TCGA, LUAD, and LUSC data sets. So the difference between the basic multiomics analysis and advanced basic analysis are 3 things. 1, input cancer subtypes, not only LUAD, but also LUSC, squamous cell carcinoma data sets are used for the multiomics analysis. Second thing is omics analysis, not only RNA and microRNA, but also RPPS, CNV, copy number variation, and somatic mutation, and maturation, CpG DNA maturation data are used for the analysis. And the third thing is, instead of concatenating the multiomics data at the first step, we decided to load onto the 1-by-1 autoencoder. I mean, if one data is missing, however, we don't have to redo from the scratch. If we concatenated these omics data first, then one omics data is unavailable. For example, we have to restart over, and it could be a waste of time. However, if we do the independently, then we can save our time, and we can generalize this multiomics analysis. That is what we thought. The other pipeline is essentially the same: data assembling, data pre-processing, and autoencoder, and hyperparameters. And the bottleneck feature space of 100 were selected by the Cox PH and applied to the k-means clustering for clustering. And this is the results. And you can see the bottleneck 100. And this is the selected features by Cox PH. And this is the results of k-means clustering. We get a k equal 2. And using this infinite level as a Kaplan analysis, Kaplan-Meier analysis is done. And we obtain the high risk, we obtain the separation of the high risk subtypes from low risk subtypes, not of the cancer subtypes. Because we are using the Cox pH as a filter, even though this is a mixture of the cancer subtypes, we are able to distinguish the patient survivors, depending on the patient survivors. Here is the results summary from the basic multiomics analysis and advanced multiomics analysis. In the next few slides, I'd like to introduce the future work. This is the importance of genome and epigenome. In the past decades, many researchers are focusing on the coding mutations, which is occurring in the exon regions, because we can assume if coding regions are mutated, protein function is also altered, so that could be a trigger for the disorders such as cancers. However, these days, one whole genome sequencing or NGS, next generation sequences are available. And analyzing these data now, we can see that there's so many mutations in non-coding regions such as 5' UTR or promoters or enhancers. That was why we wanted to focus on the pan-negative cancers, which is no mutations in exons or protein regions. And that can be addressed by the combination of genomic information and epigenetic information analyzed by ChIP-seq. So this is the strategy we are now thinking of. This is WGS data for the genomic data and a ChIP-seq for the epigenetic data, and combined with the RNA-seq, we can identify the epidrivers which is localized in the non-coding regions for addressing the pan-negative cancers, the mechanism of the pan-negative cancers. And this is the last slide. As I explained in the introduction, there's a huge difference between TCGA Caucasian data set and Japanese data set. That is why Hamamoto sensei and us are actively building the Japanese data set. And next, we'd like to use this Japanese data set and do the integrated multi-mix analysis for the comprehensive understanding of nature toward the precision medicine. Hopefully, we can able to identify the AIP drivers. This is the acknowledgements for the multi-mix analysis and the PRISM data sets. Thank you for listening. That's all from me.
Thank you for your presentation, Dr. Asada. Now let me open for a free discussion. Any question or comment? If you have a question, please write to the Q&A. There is one question. How did you decide to use Cox pH for feature selection? Have you tried other methods?
Actually, I haven't tried to use as a method. The reason why Cox pH is the OS data is available in TCGA. OS means overall survival data. So that we think if we use the Cox pH, we can select the patient or clinical related features. That is why we decided to use Cox pH. But again, we haven't tried as a method for this purpose.
Okay, next question is, it is interesting to know from the thousands of the features cut down to 100 dimensions of a bottleneck layer and down to only tens of features. Any explanation for this?
Actually, we don't know the 100 dimension is optimized dimensions. We can do the trial and the error, but this experiment we haven't tried it. Even though that advanced experiments, we auto encoded each multi-omics independently, but we chose 100 features. However, the input data is totally different among omics data set. Like gene expression is over 10,000. MicroRNA expression level is only 200, but we adjusted to the bottleneck features as 100. So it can be, can be adjusted depending on the results, but we never tried that so far. Maybe next question we're gonna address. Thank you very much.
Any other questions? Okay, now our whole presentation has finished. If you have a question to anyone, not only Dr. Asada, me or Dr. Komatsu, please write Q&A or please let me know. No questions? So I'd like to finish our presentation. Thank you so much for joining our open seminar. I really appreciate your cooperation to everybody and Riken staffs. I'm so sorry. There are some connection troubles. I do apologize for any inconvenience caused by our connection trouble. So thank you so much. And if you have an interest in our team, please see our home page. And yeah, in some cases, my email address is written in my publication. Please directly contact to me. And thank you so much for joining your participation. Thank you. Bye.